Just give it a minute and then we'll make a start, everyone. Still quite a few people joining. I think it takes a little while. There's a bit of a wait before people can be put in individually, I think. Okay, we'll make a start. Good morning, everyone. Thank you for joining this session on how can big data tackle health inequalities. My name is Kamesh Kunti. I'm a primary care researcher at the University of Leicester. It gives me great pleasure and honor to chair this session. Big data, we talk about COVID being unprecedented. However, we've seen a huge amount of access to big data, and I think UK has the best data in the world, and we've seen unprecedented publications from big data from the UK. Many of us working in big data have had difficulty accessing for many years and harmonizing some of the data, but this has happened at pace. And so we have excellent data from ONS, PHF Consortium, PHE data, ISARIC, Open Safely, Q Research. These are just some of the data sets that have been used to highlight the impact of the pandemic and for preparation for a number of epidemiological and efficacy to effectiveness data. Efficacy to effectiveness, we've seen really at pace looking at what's been seen in trials for vaccination and what we see in the real world setting. And a number of other cohorts have been funded, and we're seeing that these have been established at pace as well. So today we have three great presentations about using big data. We have questions. If you can keep the questions coming, what we'll do is the format is there's short presentations and then we'll take one or two questions after each presentation and then a panel discussion at the end. I'm joined also by Melissa from HDI UK, who's going to help me field any questions that I may miss. So the first presentation is by Rhiannon Owen on the impact of COVID-19 on socioeconomically deprived communities. Rhiannon is Associate Professor of Statistics at Swansea Medical School and Honorary Senior Lecturer at the University of Bristol. Her main interests are in the development and application of Bayesian methods in health technology assessment. Rhiannon, over to you.
Thank you very much. I'll just wait for the slides. Great, thank you very much. We can go to the next slide, please. Great, thank you. So the aim of this work was to assess the impact of socioeconomic status on COVID-related outcomes in Wales using the SAIL data bank. Now, the SAIL data bank is a large electronic cohort for all residents alive and living in Wales. And for this particular study, we selected participants who are alive and living in Wales on the 1st of January 2020, and we followed them up until the 31st of March 2021. Now, within the SAIL data bank, we have anonymised, routinely collected data, including demographic data, primary and secondary care data. And this information is essentially linked at the individual level for 80% of the population of Wales, which represents approximately 2.6 million people. So within this population, there were a total of 2,319,185 definitive COVID PCR test results recorded for 899,107 individuals. So for the purpose of this analysis, we excluded the inconclusive test results. So what does this population look like? Well, overall, the least deprived communities were slightly older than the most deprived communities, with an average age of 40.5 compared to an average age of 37.1. Around 45% were male across all deprivation groups. And the least deprived communities had a slightly higher median Charlson comorbidity score. However, the most deprived communities had a slightly higher median BMI. On average, the total number of deaths during this time period was approximately 3% across each of the deprivation groups. Next slide, please. So focusing on mortality in the most deprived communities, on this slide we have the estimated hazard ratios illustrated with a solid line, and the corresponding 95% confidence intervals are illustrated with the dotted lines. Now these hazard ratios are plotted over time to illustrate the change that we see in risk of death. So to the left of your screen, we have COVID positive individuals represented in red, and to the right of your screen, we have COVID negative individuals represented in blue. Now the solid black line at 1 represents the point of no difference compared to the mid-deprived communities. Now all of the results I will show you today are adjusted for differences in age, gender, Charlson score and BMI. So we can see from this plot that in COVID positive individuals, the most deprived communities have an approximately 20% increased risk of death compared to mid-deprived communities. However, it appears this risk decreases slightly over time and is tending to the point of no difference. You'll notice that we have narrower confidence intervals between days 2 and 54 post-COVID test, where the majority of our events occurred in this period. And this essentially increases our statistical power to detect an effect. So you can see that the confidence intervals sit above the line here. At the tail ends is where we have our least number of events. So as you can see, we have most of our uncertainty around these estimates. Now, in contrast, in COVID negative individuals, the most deprived communities have an approximately 50% increased risk of death compared to mid-deprived communities. And this result is highly statistically significant. So you can see that the confidence intervals, the dotted lines, are far away from the point of no difference here. However, over time, the effective deprivation status decreases, and at approximately 300 days post-COVID test, there is no difference between most deprived and mid-deprived communities. However, the most deprived communities remain at a higher risk compared to the mid-deprived communities for the majority of the follow-up time. Next slide, please. So how does this compare to what we see in the least deprived communities? Well, in the COVID positive individuals, we almost see the opposite trend. So where the least deprived communities are at an approximately 40% lower risk of death compared to mid-deprived communities, but this difference sort of wanes over time. And in the COVID negative individuals, we have an almost rainbow shape here, where the least deprived communities appear to have a protective effect in terms of mortality in the earlier and latter time points, but there does not appear to be a significant difference between days 5 and 54 post-COVID test. And you can see here that the confidence intervals crosses the point of no difference. It includes that line here. Next slide, please. So far we have looked at differences in mortality, but what does this mean in terms of hospitalizations? So in total, we had 469,531 admissions, representing 204,918 individuals. And interestingly, there did not appear to be a significant difference between deprivation groups in terms of length of stay or total number of admissions. This is with the exception of the least deprived communities, which is highlighted in red here, who appear to have a 9% reduction in mean length of stay for non-COVID related admissions compared to mid-deprived communities. And this result appeared to be statistically significant. But this was the only sort of key difference that we could see in terms of these outcomes. Next slide, please. So in summary, our most deprived communities appeared to have an increased risk of death compared to mid-deprived communities. And this differential risk of death compared to mid-deprived communities was larger in the COVID negative population compared to our COVID positive individuals. Now, I should be clear at this point that the overall risk of death in COVID positive individuals is higher than that of the COVID negative. And in this particular population, COVID positive individuals had an approximately 2.5 times higher risk of death. But relatively speaking, we see less of a difference in the risk of death for most deprived groups in COVID positive compared to the difference that we see in COVID negative. And that's what we've been talking about here today. In the least deprived communities, they appeared to have a decreased risk of death, but this decreased risk of death again was larger in the COVID positive individuals compared to the mid-deprived communities. There appeared to be a 9% reduction in mean length of stay for non-COVID admissions in the least deprived communities, but there did not appear to be a difference in length of stay or number of admissions for all other deprivation groups. So what are the important lessons that we've learned from COVID-19? So I think COVID, as Kamlesh mentioned, has highlighted the importance of the availability and subsequent analysis of anonymized, linked, routinely collected healthcare data at a population level. And this allows us to rapidly assess health inequalities, health services, epidemiology of disease, and key outcomes, all with a view to improve patient care and health-related outcomes. And due to the electronic and routinely collected nature of the data, this comes at no additional burden to the NHS at a time when resources are particularly scarce, which I think is a really important point. It allows us to carry out this research sort of in the background. Next slide, please. So on that point, I would just like to thank our funders, our data providers who make this data available for research, and a particular mention to the Population Data Science Health Data Research team at Swansea University, including Ashley Akbari, Rowena Griffiths, Jane Lyons and Roan Lyons for all of their hard work in preparing this data and for their helpful discussions. And I'd also like to thank Chris and Jan Davis, members of the public who provide valuable insight into the work we do around COVID-19. Thank you very much.
Thanks so much, Rhiannon. Excellent presentation. Thank you for keeping to time. I'll take one question now that's come from one of our delegates. How do you define socioeconomic deprivation, and are the public involved in that definition?
So yeah, that's a good question. So socioeconomic status in this case is defined by the Welsh Index of Multiple Deprivation, which is a sort of algorithm that we use that we run on kind of some key data, things like postcode and so on, which help us to define our most, second most, mid, least and second least deprived communities. So here I'm looking at quintiles, but you can look at deciles, for example.
So again, just using routine data rather than public being involved in.
That's right, yes, and it's kind of a standard measure of deprivation that we use across Wales. That's right.
I think it's important because we do have a number of international people who have joined, so they may not be aware of the kind of data that we're using. So Rhiannon, thank you very much for that presentation. And if you stay on, and then we'll take more questions at the end.
Great, thank you.
Our next presentation is on the epidemic within an epidemic within care homes. And here we've got Laura Shallcross, who is a consultant in public health and associate professor at UCL Institute for Health Informatics. She was recently awarded an MBE for services to adult social care. So congratulations, Laura. So we're over to you.
Great, thank you. Yeah, so I'm going to talk about the work we've done in care homes during the pandemic through the Vivaldi study. Next slide, please. So to take you back to the start of the pandemic, this slide really shows why doing research in a pandemic is difficult. So it shows deaths in care homes in the first wave, but if I can draw your attention to the red line, that shows when the whole care home testing programme came in. And so what you can clearly see is that programme missed the first wave of the pandemic. So if we want to understand what happened in the pandemic, we have a real challenge with data. Next slide, please. And so when we started this work, the questions we were trying to answer were, what proportion of staff and residents have had COVID in wave 1? And why are some care homes getting outbreaks and others aren't? And so because of the data issues, we thought the best way to get this information was to ask the care home managers themselves. So we did a survey over a 5-week period in May and June, where we phoned up over 5,000 care home managers, and we asked them to tell us about the number of infections and about the characteristics in their care homes. So were they using agency staff? What size was the care home? were there staff working across sites, those kinds of things. And then we brought all that data together within the COVID-19 data store, did an analysis and pushed our findings back through to policymakers as fast as we could. Next slide, please. And so in a nutshell, this is what we found, that around 11% of residents and 4% of staff were infected in the first wave, but clearly that's an underestimate because of the testing issues. But probably more importantly, we were able to identify some factors that were likely to be important in the spread of infection. And so we looked at infections in staff and residents, outbreaks and large outbreaks, but the red lines here show you the factors that came out as being most important across all of those outcomes. And there were key findings, say, around the fact that care homes that didn't pay sick pay had higher rates of infection. Care homes where staff worked across multiple sites were more likely to have infections in their staff. And so this was able to translate into policy decisions around the use of the Infection Control Fund, so to provide funding so that care homes could pay sickness pay and staff could self-isolate, but also to restrict movement. So a real example of how, if you can get data quickly into the hands of policymakers, you can provide a lot of valuable intelligence. Next slide, please. But we also realized that that study design could only take us so far. And so in parallel, we set up a cohort study, initially in 100 care homes, but then increased to 300. And there were three main parts to this. One was collecting samples, blood samples from staff and residents sequentially so that we could evaluate the immune response. We then linked that through to the PCR testing data and also linked through to national routine data sets, hospital admissions, deaths, and collected data direct from the care homes. And we brought all this information together in the COVID-19 data store, and that allowed us to have a very rich picture of what was going on in the care homes and to use that data set to answer important policy questions. Next slide, please. So to illustrate one of the questions, so before vaccines, people were very concerned about, could people get COVID more than once? Is this going to be an annual infection that we see? And so this graph shows you the number of PCR positive cases in our 100 care homes. And what you can clearly see is wave 1 and wave 2. And we did blood tests in around June and July, which allowed us to use antibodies to say who got infected in the first wave, and then follow those people up to see who got a new infection in the second wave. Next slide, please. And so what we found, first of all, was that a very large proportion of staff and residents were infected in wave 1, so around a third. But importantly, we found that if you were antibody positive resident, meaning you've had it in wave 1, your chance of getting a new infection was substantially reduced. So over a month period, your chance of getting COVID was around 1% if you were antibody positive, but it was around 7% if you were antibody negative. And so this really illustrates the protective effect of antibodies, something we've seen in healthcare workers, but also to see it in this frail, vulnerable population, really important, but also encouraging for vaccine effectiveness. Next slide, please. But as this is the HDR conference, I thought it was useful to reflect a bit on what we've learned about doing research in a pandemic. And I think the first thing to say is it's remarkable that we were able to do this research with linked data in care homes. And I think that if we can do it in a pandemic, then we really ought to be able to do it outside of a pandemic. And so we've started having these conversations with the public through our patient public involvement group and saying that what would need to happen for us to work in partnership beyond COVID. And to leave you with a couple of quotes. So, but I do think you need to continue with linked studies, especially around transition between settings, so NHS social care. We don't know what the future holds in terms of other waves and new variants, so this work needs to be ongoing. Next slide, please. So I will leave you with that and to say clearly this has been a huge team effort, but I'm optimistic that we can build on what we've learned to create a better resource for care home research moving forward. Thank you.
Laura, thank you again for an excellent presentation, keeping to time. I've got a question here for you from one of our delegates, very linked to your last slide. saying, other than the introduction of the whole care home population data flows, how are we better set up for the future to protect our older adults more effectively in the next wave or next pandemic? Are all these changes fully embedded, and we know that data flows happen so quickly? Do you think they will stay forever?
I really hope so. So obviously at the moment we're reliant on the COPI notice. Our conversations with care homes suggest there is an appetite for finding a way to keep bringing in data from care homes beyond the pandemic. All of this currently is possible because of the testing program. That's how we know who's in a care home. Once that stops, we lose our surveillance. So my view is that we should start doing this on a voluntary basis, working with the care homes, demonstrate what we can give back and how useful it is, and then look at scaling up.
Okay, thank you very much. And again, we'll come to a number of questions that are coming through, which are generic questions. At the end, if there are specific, I will guide them to the relevant speakers. We'll go to our last speaker on health inequalities amongst ethnic groups, Vey Nafilian, who has been working tirelessly and produced a number of publications in relation to ethnicity. Vey is a statistician working at the ONS and London School of Hygiene and Tropical Medicine. His research interests include estimating the health effects of social policies and studying health inequalities. Vey, over to you. I think they did have, he did send me a text saying he was having problems. Oh, there we are.
There you are, perhaps on mute.
Hello, sorry about that.
Wonderful. We can hear you now.
Can you see my screen? No.
Yes, yes.
Yeah, oh, perfect. Okay. Sorry about all the IT issues. I guess 1 out of 3 isn't too bad. Yeah, thank you very much for this kind introduction, Kamlesh, and I'm delighted to be here to present today some of the work that we've been doing at ONS. So I'm presenting the work, but as you'd expect, it's a big teamwork that we've been doing over the last year. And I'm going to talk about ethnic inequality in COVID-19 and mortality and also vaccination coverage, if time allows. So as has been said before, so monitoring inequalities in health outcome is very important, especially during a pandemic. And in a pandemic, timely evidence is needed. And that's something that we've tried to do. So the existing data sets are limited in terms of how you can use them to look at inequalities, because surveys are really useful for looking at inequalities in terms, because you know a lot about people, but they are quite small, and therefore that can limit the empirical analysis you can do, and they're also expensive and relatively slow to set up. On the other hand, you've got electronic health records, which are very important because they provide population level data sets, and that can allow people to look at inequalities in detail and looking at groups. The only drawback is that they lack a lot of social demographic characteristics that can be useful to look at when you look at inequalities. So what we've done at ONS is trying to, I mean, you've seen a presentation based on sale data in Wales, so it's trying to create something similar in England by linking this 2011 census to electronic health records and mortality data to explore health inequalities during the pandemic. So we've created a data set containing data on about 40 million people aged 9 or over that were alive at the beginning of the pandemic. And we have a lot of different information on the demographics, socioeconomic characteristics, some information on occupation, all from the 2011 census. And then we also have information on medical history derived from the GP and the primary and secondary care records, and also on geographical factor that we use on the 2019 patient register. And we do cover, we do have a relatively good coverage. We cover about 80% of the population and about 90% of the 65 plus. So some work we've done is trying to estimate the differences in COVID-19 mortality in the general population over the course of the pandemic. So looking at two waves, probably wave 1 that we define up to the end of August, and wave 2 after. And the way we've done it, and we've tried to understand, understand why we observe differences by adjusting for characteristics. So here what we show is the difference, the relative difference in the risk of COVID-19 related mortal deaths compared to white British for different ethnic groups. And it's the result from different models that adjust for different things. So in purple, it shows the model that just adjusts for age. So that's the best measure of inequality. So you just compare people from different ethnic backgrounds with different of the same age. And then we find stark inequalities with particularly among people from Black African, Bangladeshi background, also Pakistani and Black Caribbean. I mean, all ethnic minority groups are elevated risks for males and all but Chinese for female. And the magnitude is extremely large. I mean, like 4 times more likely to have died. It is extremely large, far larger than you would expect when you look at inequalities for disease, especially for non-communicable disease, where a relative risk of 1.5 are deemed large. But here it's up to 4 times in the first wave. So what we did is by adjusting for the factors, we can try to understand a bit what are the differences, what explains the differences, and we can see that a lot of it is due to population density and regions where people live explain quite a lot of the difference, especially since in the pandemic the infection spread differently in different areas. So it's important to recognize that. Then further adjusting for social demographic factor in the first wave did reduce some of the inequality for some groups, such as Bangladeshi males or Pakistani, but not massively. I mean, you need to understand. We need to be aware that obviously population density and region are also correlated with social demographic factors. So that's perhaps a reason why it's not it doesn't make such a big difference. But we also adjusted for pre-pandemic health using medical history for the past 10 years, and we can see that it doesn't make a big difference for most groups, except Bangladeshi males and female. It does make quite a big difference. So now if we look at wave 2, so the first half of wave 2 really up to the end of January, we can see that the pattern has changed slightly, especially for Black Caribbean and Black people from Black African and Black Caribbean backgrounds, where the risks have been reduced drastically. The relative risk compared to the white British have been reduced drastically compared to the first wave. So they're still at elevated risk, but they're only moderately so compared to the first wave. But on the other hand, what we can see is that the relative risk has increased dramatically for people from Bangladeshi and Pakistani background. And what we can also, another interesting conclusion, that the role of geography has decreased, but the role of social demographic factors has increased in explaining these differences. So that's quite an interesting, showing the dynamics over the course of the pandemic and how it's changed. So what we can see is that the reduction of here is a different pattern that suggests that the differential mortality between the waves are really driven by differences in infection rather than differences in severity. So we've seen very large differences in inequality in COVID-19 mortality, and the changes between wave 1 and wave 2 are interesting because they show that the differences are likely due to differences in infection, but it's also a hopeful message in a way, because it shows that policies and interventions can help reduce inequality. So all this means that we need to target policies to prevent infection in the most vulnerable groups. So very quickly, what we've done as well is looking at inequality in vaccination coverage by ethnic group, because we've seen that these groups are at elevated risk of infection and mortality. And what we find, and is very worrying, is that they also have lower vaccination rates. And because we stopped the wave 1 analysis by the end of January to a period where the vaccination rate was still relatively low, we can be confident that unfortunately these inequalities will increase because of the vaccination rate being dramatically lower among people from Black African and Black Caribbean and also Pakistani background. So we are continuing to do some work on monitoring the uptake, but this is very important that policies and intervention are put in place to promote vaccination among these communities. Okay, I think I'll stop there.
Thanks again. They just shows the power of the whole population data that we've seen from you. and from the sale data set. I'll ask you a question, then we'll get the whole panel together. Someone sent this question in before you showed us the data for the second wave, but it's still relevant that we saw a lot of important observational research on effects of COVID among ethnic minority groups. What lessons have we learned, and what's actually happening now to improve the outcomes? And you've touched on it. Is there anything else you can add to that at all?
I mean, I think that especially in the first wave, because the reporting of all so that when we initially published in May and coincided with the first Open Safely paper showing elevated mortality among people from ethnic minority groups, it coincided with a Black Lives Matter event. And I think because of that, there was in the media at least more focus on the fact that Black people were elevated risk, and that might have led to more interventions being targeted towards them rather than to other groups, and that could explain what we see the big difference between wave 1 and wave 2. And I mean, Kamlesh will be able to tell you more about this, but in the SAGE ethnicity subgroup, we've been doing some work trying to design intervention and evaluate interventions to prevent infection in some of these South Asian groups.
Okay, thanks very much. Shall we bring the whole panel along now? I think we're all here. There's a few questions coming up. Just raise your voice if you want to answer. More than happy to take a number of answers to this. As a question which is very, very relevant, obviously, do you think that the recent negative media attention on sharing of NHSD GP datasets will lead to opting out amongst community groups that results in further inequalities? And what role can research play in mitigating this? I mean, this is such a hot topic at the moment. There's a lot of terrible media going out there. HDI UK had a response. A number of us did a media briefing on this, that really people shouldn't opt out because we've seen the power of big data during the pandemic, and we'd like to capitalize on that post-pandemic. So anyone would like to take that?
I can start from a sort of Welsh perspective. So we've had a really great, very successful start with linking this electronic health record data, and there's been a huge buy-in from the Welsh population. So we currently have 80% of both primary and secondary care data linkage. So 80% of the population, which is huge. And I think one of the key things to sort of promote, and so in answering your question about how might we address this, is that the kinds of outcomes that we've been able to assess and the kinds of policies that we've been able to sort of inform through our research has largely been motivated by analysing this population level data, which we wouldn't have been able to do without that buy-in from the Welsh population. I think one of the things as well that's very important is that we are looking sort of specifically at both similarities and differences across the UK, and that's a really, really important thing to look at, and it highlights the issues around these health inequalities. So we often see that there are different health inequalities across the nations, and it's important to unpick those, but also sort of come together as one to see how we can tackle them.
Thanks. Anyone else like to take this? I don't know. I'm sure you're having discussions within ONS as well.
Yeah, no, absolutely. It's crucial for research, for public health research, that this data set goes ahead without too many opt-outs. So I think communication is key here, and probably wasn't handled very well initially, but there are some efforts. I know the National Statistician Ian Diamond is now involved in helping communicating the importance of collecting this data for research purposes.
Okay, great. Laura, anything to add?
Yeah, I mean, I think that the points about communication are really key. I think when people get upset about it, it's because they feel they're not being told, or they haven't had the opportunity to express their views, be listened to. I mean, that's certainly, we're starting to try and have these conversations in care homes, as I said, and I think it's all about engagement and demonstrating why this is of value to those stakeholders. It's no good doing research if you can't demonstrate why should they share their data with us. It's our job to make that clear.
Okay, thanks. This question came up in the previous session, but I think it's still relevant here. And it says, may I know the reproducibility of the results? Some or more research studies on COVID-19 don't provide the same results as published. What do you suggest? And it's very relevant because all these databases were not accessible by researchers previously. Now, a number of research groups have access to ONS data, BHF consortium data. So in terms of reproducibility of the results, what would you suggest? Anyone from the group?
I mean, if I can just say something in terms of, I mean, there is two things I think in reproducibility. One is that in a different data set, you find similar results. So we've been doing quite a lot of work with working closely with people from Open Safely and comparing our results. And it's quite interesting because it's two data sets with slightly different coverage. And at the beginning, Open Safely had all the clinical records and we had none, but we had more social demographic characteristics. So it was very insightful to compare the results when we adjusted for different set of characteristics. So we've done quite a lot of work. We've also done some, I think there is a lot of value in replicating studies to an extent in different data sets. So we've done the validation of the Q-COVID risk model, which is a predicted risk model used by the NHS in clinical care, and also to inform the vaccination prioritization. So we've done a lot of that. So I think, yeah, that's an element of finding similar results, consistent results in different data sets. And the other one is making data available. This has been difficult, but we're getting there now. So for instance, all our data are available on the Secure Research Service for researchers to use. So you should be able to hopefully reproduce the number I've just shown you. It's because we do, in terms of reproducibility, just a small note. It is difficult because the data are never really finalized. For instance, the death data are added constantly, and even retrospectively, because some deaths it takes very long time to register. So you might not be able to reproduce exactly to the fourth decimal place the results because of the data being updated regularly. So the data on the SRS will be slightly different to the data that we've used because they are more they include primarily finalized data, where we've been working sometimes on provisional test data.
Anyone else want to add to that?
Yeah, I think in addition to sort of data availability, which I think is a very important point, I think another aspect that we all need to work on really is providing statistical analysis plans, clear statistical analysis plans that are publicly available. And with sort of the development of Git repositories and things like that, we should be able to make our code available so it can be directly taken, edited slightly, and sort of applied in other data sets, so that other researchers know exactly what we did, the exact assumptions that we made, and can reproduce them in their own data sets.
Right, there's another question. Great work by showing ethnic inequalities that can be addressed. How can other countries who do not collect this level of population data learn from this? I think ethnicity coding is not brilliant in the UK, but it is probably one of the best data sets, I think, globally. We also have a diverse ethnic makeup. But ethnic coding is not consistent. I know the census is happening now, and you probably have been thinking about the way ethnicity data is coded. Anything from your end?
I mean, this work demonstrates the importance of linking data together and having micro data available. So to answer the question, I think it was primarily in countries where you don't have this data, it's going to be very difficult to do, and it demonstrates the importance and the value in a way. I mean, we were talking about this, like to convince people to give their data. It demonstrates the value that things that we can do in the UK cannot be done in other countries, because simply don't have the data. And I think maybe showcasing this more would be very useful for people to understand that it's easy to see what you have. It's easy not to see what you have, but when you realize that what you have is quite unique, it makes maybe a bit more valuable.
Anyone else want to add anything at all? Otherwise, no. Okay. This I'm going to take this for everyone. Quite an important question here, and you may have already started these collaborations. The question is unequal COVID impacts within care homes amongst ethnic groups and socioeconomic groups that you've presented have not been limited to the UK. And how important are international data collaborations been tackling this? And I'm just going to add to that whether you've had discussions with international collaborations. Maybe Laura, I'll start with you.
Yeah, so we have. So we've been working a bit with LSE, who have a COVID recovery project. And so we're doing joint webinars with a group in Canada who are also looking at immunology in care home residents. So we're starting to do that. Of course, there are all the challenges that care homes are set up differently in different countries, and how do you make those comparisons? But yes, and I think that moving forward, it's extremely important that we try and learn lessons from other countries, not just about the pandemic, but more broadly about the surveillance systems that they have in place and how they share data.
Rhiannon?
Yeah, I would agree with what Laura has said, and I think it's really important that we learn from each other. I think one of the barriers moving forward in terms of international collaboration is within the data sharing sort of agreements. They become more complicated across borders and so on. And I think that's an area that we particularly need to work on, but is something that we should strive to do, because if we can do this on a larger scale and look at what's happening sort of globally and not just sort of within the UK, I think it would be really beneficial. I think it also links back to what we were saying about reproducibility and how we can best help to facilitate the learnings across borders.
Yeah, we've been doing some data looking at diabetes outcomes in people admitted to hospital using admission data. And we see a major difference, as you've seen in the UK, ethnic minority groups disproportionately affected. Just looking at the French data, and they don't have an increased risk in the ethnic minorities who were admitted to hospital like we do. So we're still sort of baffled why that's the case. There may be lots of reasons in a healthy migration bias, etc. But it is really interesting to look at that data, and really important to look at that data. The other problem is coding. Ethnicity coding is so different in different countries, and I think that's something that definitely needs to be looked at. Anything to add in terms of collaborations that you've been thinking about?
I agree with what has been said before, and it's probably something that we haven't done enough of, and we are starting of doing more of now. But as you say, it's difficult. It adds another level of difficulties about data sharing, but also comparison. And as a National Statistical Institute, I know we are trying to. We've been working, well, sharing lessons with some national statistics institutes across the world, but we are doing it more and more. But yeah, something that we do need to do more of, I think.
Yeah, there was a very early on publication, and they looked at clinicalgov.com, and from all the thousands of studies that were registered, only 6 said they were collecting data on ethnicity. These are global studies, obviously. And I think this was probably pre-identifying that ethnic minorities were disproportionately affected. So I think that certainly needs to change. All of you have been working with diverse data sets and harmonizing data sets. So this is a question, how far is diversity of data a barrier to research you've been doing, and what can be done to overcome this? Maybe again, I'll start with Rhiannon.
Yeah, I think diversity of data is a really great thing. It's what we want. We want to be able to link lots of different data resources, but equally it can become a barrier. It's certainly been a barrier in some of the work that we've been doing in terms of getting these databases to talk to one another and to get sort of sensible results. So for instance, I would sometimes link these data sets and realize that a COVID test was sort of recorded for an individual maybe a week after their mortality record and things like that. So it can become quite difficult, particularly on a large scale, to identify some of these anomalies. But having said that, I think the diversity is really key. We can answer so many more questions by having a sort of full picture of somebody's health records, their demographics, sort of what influences behaviours and things like that. So the more data that we can gather on an individual at a linked level would be really beneficial.
Okay, Laura?
Yeah, I think this is a real challenge. So what we've done is we've started with the basics, essentially. All we're trying to do is find out who are in these care homes and then link to all the other routine testing data sets. But what we've really noticed is it is easy comparatively to do research in care home chains, because you go to one person and you have access to data from 100 care homes.
Yeah.
When you start getting into the territory of independent care homes where everybody does everything differently, it's so much more challenging. And so there's a complete inequality in terms of research there. And it's something we're trying to address, but it's very challenging.
And Dave?
Yeah, so talking about diversity of data, I think what has happened over the course of the pandemic, and we've seen loads of people working on different data sets. And I think as researchers, it's great because you've got different pictures that complement each other. The only drawback is sometimes it might be a bit confusing for the public to see different results and different messages coming from different data sets. And usually there are good reasons why the messages are different, but it's communicating these differences can be quite challenging. And for policymakers, it's the same. So, working for the government, we always have to try to, coherence is a big, very important. And sometimes it is made more difficult by having a wide range of data sources that people use in different ways and that are not harmonized. So I think, as researchers, it's brilliant. Sometimes for the public and for policymakers, they probably wouldn't agree that it's always great. But I think overall, it is a good thing. And I think working more across organizations help, understanding the reason for differences. And as long as we can explain them, I think it is really useful.
Great, thanks. This is from Matthew Redford. This is for you, Laura. Wondering if there's been any work into the difference in transmission rates, mortality rates between people in care homes compared to those who have domiciliary or home care.
Yes, this is a question I've been asked once or twice. I'm afraid we have only been able to do work in care homes so far. And so there is, of course, increasing recognition that there are a huge amount of people receiving care in their own homes. And it's an area we really need to look at. But of course, the data challenges there are even greater than the data challenges in care homes. So I think as yet, nobody has had a really good idea about how to try and solve that.
And this is a question, it says to all speakers, which communities do you think are the most impacted by research or work that you have completed during the pandemic? Having said that, Rhiannon and Babe are using routine data, not directly impacted, but you may have views, but maybe Laura, if you wanted to comment on that one.
Yeah, in terms of how the work that we have done is added to workload or that kind of.
Yeah.
I mean, we have really tried to design our study to minimize workload on the care homes, because clearly during a pandemic, it wouldn't have worked otherwise. What we have been able to do is to do a lot of blood sampling in care homes. And so we've had private phlebotomists who've been going in with all the PPE and testing concerns that that's brought. And we've done that by working very much in partnership with the care homes and centralizing all the administration. So it's not care home managers who've been doing it. But yeah, I mean, it's a significant amount of work. We've also been able to resource it through our study, which has helped.
Okay, great. I think we are at the end of our session, and there isn't a break next session straight away. So I think we should close here. But there is a comment here from Paul Docrace in Cambridge County. Compared with other countries, we may be ahead with all the ethnicity reporting, while GP practices is still not brilliant. Some practices are good, some practices not bad, and there's a data completeness and data quality issue. I think the only way you can do this, improve in terms of all the data, is make it mandatory. These are some of the things that there have been discussions about making data mandatory, ethnicity mandatory when patients are registered with practices on an ongoing basis as well. But we will end there in view of time. Thank you so much for great presentations, keeping to time, and thank you for taking all the questions and answering them adequately as well. All of you have a great day, and we see you in the next session. Thank you. Bye, everyone.
Bye.
Goodbye.